Thank you. All right. As you all know, transplant topic is always a dry topic, particularly when it's actually presented at the end of the day, the second half of the day, where everyone else wants to go back home as soon as possible. We're trying to make sure, because we know that transplant anesthesia or transplantation programs never been part of core topics in anesthesia master's program. Unlike our conventional topics such as cardiac, neuroanesthesia, pediatric, regional, and so on, only certain hospitals in Malaysia do have this, what do you call that, exposures to transplantation, be it kidney or liver. I would like to highlight that Hospital Selangor is the only public hospital in Malaysia that offers transplantation programs for both kidney and liver, whereas Hospital Kuala Lumpur is the only center that provides or caters for kidney transplantation. As a result of that, not many candidates around across the nation have experienced transplantation anesthesia or have undergone. I've seen any one of these, but you must understand that if you look at the National Registry of Transplantation, just published recently in September 2023, there are about more than 10,700 people still in the waiting list for whatever transplantation, whether it's kidney, liver, and the majority of that, but the bulk of that, almost 90%, more than 10,300 people are on the kidney liver transplant program waiting list, whereas the rest will be liver, cornea, bone, and et cetera, et cetera. As a result of that, I just want to highlight to you that although this sounds very dry, but it's very important for everyone here and on the virtual platform that it is very important, because to know it, to experience it, to love and understand it. And as a result of that, we have two very eminent speakers today, especially what we call that, hand-selected by the organizing team members to present this topic. Without further ado, I would like to call upon the first speaker, which is Dr. Sharini from Hospital Selangor. Well, she is one of my trainees in the past. So she has just completed subspecialty trainings in liver transplantation anesthesia in May 2023. She was born and bred basically in Selangor. So like most of my candidates or most of my trainees in liver transplant program anesthesia, they were all hand-selected because all of them were from Selangor. Also because this anesthesia involves a lot of dedication, hard work, and long working hours, and not many people are willing to put efforts into joining. And as a result of that, these people are really very, what do you call that? I send my highest gratitude to you for being one of my successful trainees. She just completed hers in 2023. Without further ado, I would like to invite her to present the topic on the role of anaesthetists in donor identification and management. Welcome, Dr. Sharini.
Thank you very much, Dr. Jaime, for the kind presentation, for the kind introduction, sorry. Okay, before I start my talk, allow me to first give a brief introduction about liver transplant anesthesia, because a lot of people, even in our anesthesia fraternity, do not know the existence of this subspecialty program. Okay, this is Hospital Selangor, where I work. So Hospital Selangor is the only liver transplant center in Malaysia. Okay, there are 4 of us currently in the liver transplant anesthesia team, headed by Dr. Jaime, and that's Dr. Haslini, me, and Dr. Nashazli. So as part of our job scope, we see patients pre-operatively to make sure they are optimized for a liver transplant and make sure they are ready to be transplanted whenever an organ becomes available. At the same time, we manage them intraoperatively, and post-operatively, we are also involved in managing the patients together with the primary team, especially during the acute period, until they are stable enough for them to be managed by the primary team themselves. A lot of times when people hear we are doing liver transplant anesthesia, the question I get asked, does Selangor actually do liver transplants? I heard they have stopped doing liver transplant for a long time. And the other thing is people say that all our liver transplant recipients die. So I would like to say that this is not true. For the past few years, the number of liver transplant that we have done has been increasing. Okay, and of course, not all our patients survive, but about 60 to 70% go home alive. As you can see from this graph, the number of cadaveric liver transplants, as you can see from this slide, the number of cadaveric liver transplant far outweighs the living related liver transplant. We rely a lot on the cadaveric donor pool. So we don't really get much notice when the liver transplant. Most of the time, it's 1 day before kind of notice. Okay, so as what happened in August of this year, we got an update. This WhatsApp group, as everywhere, it's a norm nowadays. A transplant coordinator sent a message saying there's a referral, a potential organ donor from Hospital X. She's a 71-year-old lady with a blood group O positive, which means that she's a universal donor. She had suffered from severe traumatic brain injury, and first brain death test was positive on the 26th of August at 10 a.m. A second test was planned at 4 p.m., but the family had already approached the physician there for organ donation. Not too long after that, the hepatology team updated in the group that they have had a referral from Hospital Y up north. They had a 25-year-old lady with acute liver failure, secondary to acute fatty liver in pregnancy. She presented at about 36 weeks of pregnancy with acute liver failure, and so had an emergency Caesar done. She was intubated for the surgery, but she never regained consciousness after that. She had AKI requiring CVVH, and her serum ammonia was sky high. So the hepatology team had already accepted the referral, but they planned to transport her over to Selayang the next day. All acute liver failure patients are referred to the hepatology team, and if the patient is feasible to be transplanted, they will be sent over to Hospital Selayang, where they will await the liver to be available. So later on that day, the second brain death test was done for our potential donor, and it was confirmed that she was brain dead. The consent was obtained from the family for liver, kidney, and cornea donation. That same night, the patient from Hospital Y was transferred to Hospital Selayang ICU. She arrived in the ICU at about 1 or 2 a.m. in the morning. The next day, the procurement surgery started in Hospital X at 3 a.m. and the GA for our patient started at 6 a.m. The surgery itself started at 7 and completed at about 5 to 6 p.m. Day 1 post-op, the patient opened her eyes, and day 2 post-op, she was extubated. She went through a very stormy period, actually. She had, the AKI was there, however, she never needed dialysis again. She had nosocomial infection. She had acute rejection requiring pulse of methylprednisolone. She was very weak and required a lot of rehab and physio. But eventually, after a long stay in the hospital, she was discharged home on the 4th of October. It all seemed very easy. You know, there was a donor, there was a recipient, the transplant was done, and the patient was sent back home. But actually, there's a lot of background work that we don't realize. And we don't realize that the anesthetist plays a major role in finding the organ, in getting the organ, and in donor identification as well as management. We are actually involved with these potential brain dead donors from the almost very first presentation to the hospital. The moment they're intubated, they're ventilated, they're already referred to the NS team. Of course, for instance, in cases of severe TBI, the initial therapy would be the patient management, would be preservation and restoration of the neuronal function. That is our main aim. However, when our primary treatment is unsuccessful, if the injury is just too severe, the patient may progress to go on to being brain dead. In such a state, so we have to be able to diagnose that a patient is brain dead, do a brain death testing, and offer the family the opportunity to donate the patient's organs or tissues. If the family agrees to donate the organs, then we have to now manage the donor in the ICU. It's no more about the patient's primary illness. It's now managing the organs so that it is feasible to transplant this organ into another patient. We have to do a thorough preoperative assessment of the donor, transport these critically ill patients to the OT, as well as manage the patient intraoperatively. Now, this topic is very close to my heart because donation after brain death is the main source of organs in Malaysia. Although our rates have been increasing in the past few years, it's still not enough. There are still many patients who are waiting for months on the transplant list. There are still patients who are dying on the transplant list while awaiting an organ. Death is defined as a permanent cessation of the coordinated function of the organism as a whole, and brain death is basically death by a neurologic criteria. When we tried to prognosticate these brain dead patients, I only found a very old study actually. It's a study published in 1981. They went back from 1962 and found 609 neurosurgical patients who were diagnosed with having brainstem death. When they went through the notes, they found out that cardiac asystole occurred in more than half of these patients within 30 to 40 hours of ventilatory care. In the other 46%, ventilation was withdrawn because the treatment was futile. So it was concluded that continuation of artificial support for patients who are clinically brainstem dead is futile. This is the outline of my presentation. I'm going to just briefly touch on each topic, and I will put my references for each subtopic as I go along. I'll start off with donor identification. So there is something called a gift trigger. So these are 4 signs that we should look out for in a patient, which may point to the fact that patient may be brain dead. Okay, it is not a brain dead test by itself, but it is just a trigger so that you can inform either the UPO team, the top team, or the NTRC team, depending on your hospital setup, so that a brain dead test can be done in the once feasible. So it is GCS 3/15. Patient has to be intubated and ventilated. Pupils are fixed and dilated, and treatment has been deemed to be futile. Other things that we should look out for is a known cause of irreversible loss of total brain function. The sedation has been off for more than 24 hours, and absence of cough and gag reflex, as well as no spontaneous breathing. There are 16 main hospitals currently with the UPO team, and their job is to obtain consent for organ donation, providing support for donor families, coordinating the procurement of organs, as well as educating the public and increasing donor consent rates. I'm going to move on to brain death testing. In 1995, the American Academy of Neurology came up with this guideline. They said that 3 clinical findings are necessary to confirm brain death, being coma with a known cause, absence of brainstem reflex, as well as apnea. So they proposed a series of clinical tests of the cranial nerve and the respiratory center. And they said that this has to be done on 2 occasions, not to confirm the diagnosis, but to reduce the risk of observer error. Recently, there was an updated guideline produced by the same academy about brain death testing as well. I'm going to go through the statements outlined by this in this paper. Okay, so brain death test cannot be determined in infants younger than 37 weeks corrected gestational age. And to avoid conflict of interest, as clinicians, we should only consider the interest of our patient. Okay, we should not be involved, do not have any direct involvement in decision making regarding organ donation. Statement 4 is a very, very long sentence, but all it's saying is the patient has to be cared in a critical care environment. All attending clinicians performing the brain death test should be appropriately credentialed, trained, and competent to evaluate a brain death, to perform a brain death test. In Malaysia, the requirement is that the person has to be a specialist for at least 3 years. Before we perform a brain death test, there are a few prerequisites. First, we have to ascertain that the patient has suffered a catastrophic permanent brain injury caused by an identified mechanism. And the neuroimaging should be consistent with the severity of the brain injury. We have to wait a sufficient amount of time to make sure that the patient has no potential for recovery. We have to ensure the patient is not hypothermic, not hypotensive, and does not have any metabolic derangement. We have to make sure all medications and any drugs that can cause depression of the CNS can be excluded or have already been eliminated. You can either do a drug toxicology test, or you have to wait for 5 half-lives of the drugs to have passed in a patient with normal renal function. The brain death test itself has many components. First of all, you have to ensure that the patient is comatose and unresponsive to any type of stimulation. You have to assess the motor response of the patient after application of noxious stimuli to the head, face, trunk, as well as limbs. There must be no pupillary light response to bright light bilaterally. The oculocephalic reflex should be done in all patients. However, if there is a concern for cervical spine injury and the test cannot be done, the oculovestibular test has to be performed. If the oculovestibular reflex can be done, and all other brain death tests point towards the patient being brain dead, then you do not need to perform an ancillary test for this patient. Corneal reflex, gag and cough reflex, as well as the sucking and rooting reflex in infants younger than 6 months of age has to be negative as well. Apnea testing is a mandatory component of the brain death test. At this guideline, they mentioned that only 1 apnea test is adequate for an adult. However, in my setting, we always do two apnea testing, one after each cranial nerve testing. So before performing the apnea test, we have to ensure that the patient's risk of cardiopulmonary decompensation is acceptable. A lot of times, the brain death test itself can cause a lot of hypoxemia as well as hypotension and cardiac instability in the patient. The patient's baseline PaCO2 level and pH should be normal, and you should pre-oxygenate with 100% of oxygen for at least 10 minutes prior to performing the test. To ensure adequate oxygenation during the apnea test, there are 3 different methods. In Wilayah, we normally do the first method. We disconnect the ventilator, we put in a catheter delivering 100% of oxygen at a rate of about 4 to 6 liters per minute. This catheter should be less than 70% of the ETT diameter to avoid barotrauma to the patient. You can also deliver 100% of oxygen via CPAP on the ventilator, but if you choose this method, you must make sure the backup apnea ventilation is switched off. The third option is to disconnect the ventilator and delivering 100% of oxygen through a flow inflating resuscitation bag with a PEEP valve. It has been suggested that for pediatric population, option number 2 and 3 be done. After about 8 to 10 minutes of apnea, you should take an ABG for the patient. If during this period of time there is no respiration, arterial pH, and you can achieve an arterial pH of less than 7.3 and a PaCO2 of more than 60 or more than 20 from baseline level of the patient, then you can conclude that this is consistent with brain death. However, if you do not achieve this level, you can continue with the apnea test and keep the patient off the ventilator as long as the patient is hemodynamically stable. However, if the patient develops hypotension, desaturation, or has an arrhythmia with hemodynamic stability, the apnea test has to be stopped. As far as possible, try to get an ABG before putting the patient back on the ventilator. If the ABG and the pH has achieved the level required to confirm brain death, then that is adequate. You can confirm the patient is brain dead with that reading. However, if it does not achieve the level needed, then you have to repeat the apnea test when it can be safely completed after resuscitation of the patient or perform an ancillary test. The ancillary test is done only to assist with the diagnosis of brain death when the neurologic examination or the apnea test cannot be safely completed. You still have to do all the components of a brain death test and the apnea test as far as possible. So the situations in which an ancillary test may be needed, okay, are like when you have injuries to the cervical spine, skull base, or facial injuries. These will make neurologic examination of the patients to be difficult. If there's injuries to the cervical spinal cord, the patient may be paraplegic and may not have a spontaneous respiration, so your apnea test may not be accurate. So in these kind of cases as well, ancillary test is mandatory. Patients who fail the apnea test because of cardiopulmonary decompensation may need an ancillary test as well. And patients who suddenly have limb movements and you're not sure whether it is a spinal reflex or patient's motor movement, then you need to consider doing an ancillary test as well. You do not need a consent before you do the brain death test, but you should try your best to inform the family that you are going to perform a brain death testing. Time of death is the time of the final apnea test, or if an ancillary test is done, the time the clinician, the radiologist documents in the medical record that the results are consistent with brain death. So this is part of the brain death certification form that we have in KKM. Okay, so these are all boxes then you need to check, okay, all the preconditions, all the tests that needs to be done and need to be marked before you can confirm that a patient is brain dead. Spinal reflex movements that you can see in patients who are brain dead. Okay, there was a newspaper article published in UK in 2016. The dead man raised up his arm because of an extraordinary medical phenomenon. To the lay person, it may look something impossible. You have already certified that the patient is dead. But actually, it is just something that is occurring at the spinal level. It can be present in about 40 to 50% of heart-beating cadavers of patients who are already brain dead, and it can last for up to several hours or several days. So this is a systematic review about movements in brain death. So Saposnik G et al. Had a multi-center study where 107 heart-beating cadavers were studied who fulfilled the criteria for brain death. 44% had spontaneous or reflex movements. The most common is the undulating toe reflex or the triple flexion response. And they noted that most of these movements occurred in patients who had intracerebral hemorrhage, and it's not so common in patients with anoxic ischemic encephalopathy. Some even had more than one type of movement. So there are many different kind of movements that you can see, and you will never know that, which patient is going to show which kind of movement. So it's usually seen during hypoxic stimulation of neurons in the cervical spinal cord, when you remove the ventilator support during apnea testing or during arterial hypotension. I myself have had this experience. Actually, we disconnected the ventilator from the patient for the apnea testing, and there was facial movement. It was a facial myokemia. Patient did not desaturate, and we were able to complete the apnea test until the end and pronounce the patient to be brain dead. But when we put the patient back on the ventilator, the movement stopped. About half an hour after that, just to try it out, we disconnected the ventilator again, and again the movement came back. And it's the same movement, the same side of the body and the same movement. Sometimes mechanically induced movements through passive neck flexion and noxious stimuli also can cause some movement. Again, this was witnessed by my friend, again in Wilayah, when we did a brain dead testing. They flexed the head of the patient, and the patient carried up his legs, flexed the legs, the triple flexion response. So DeQuinn and colleagues proposed that maybe spinal reflex occurs because of mechanical extension of the spinal roots or direct compression of the spinal cord or due to some sensory input stimuli. But all these are just postulation. No one really knows why it occurs. So how do you differentiate it? A spinal reflex does not occur with stimulation of cranial nerves and usually is triggered by stimulation below the foramen magnum. It is precisely repeatable. The same movements occur every time the same stimulus is placed for this patient. And the other thing is all other elements, all other tests that you do are compatible with brain death. However, if at all you are in any doubt, you can perform an ancillary test for reassurance. So I'm going to talk next about donor ICU management. Okay, these are my references. So the management of the patient in the ICU starts with the medical management of the patient before the patient is brain dead. But once death has been declared, now it is the management of a potential organ donor. When we talk about the cardiovascular system, an increase in ICP causes reduced brain perfusion, activation of the sympathetic nervous system, which leads to a catecholamine surge, causing an increased PVR, increase of heart rate, increasing myocardial oxygen consumption, and decreasing myocardial perfusion. And as a result of that, patients can have a loss of vascular tone and fluid regulation, hypotension, and rhythm disturbances. Giving a beta blocker early on during the phase of activation of the sympathetic nervous system can help prevent this cascade of events. So when you talk about the hemodynamic management of the patient in the ICU, is as per any other patient in the ICU. We would already have an arterial line or a CVL in place. Bedside echo is useful for fluid management of this patient. The issues that we can face are tachycardia and hypertension during the sympathetic stimulation phase. As I mentioned before, a short-acting beta-adrenergic antagonist such as esmolol can help preserve the myocardial function if given early on. However, if the patient has already progressed to hypotension and arrhythmias, once fluids are adequate for this patient, we should start with either noradrenaline or vasopressor for this patient. Vasopressin. So renal and metabolic management is closely related to the hemodynamic management as well. Aim a urine output of more than 0.5 mL per kilo per hour with a normal pH and aim a serum sodium of less than 155. Hypernatremia has been associated with primary graft rejection in liver transplant recipients. You can assess fluid status clinically or with a bedside echo. Once fluid is adequate, consider vasopressors to keep your MEP. You can use isotonic or near isotonic crystalloids. Colloid solutions are acceptable, but avoid starches as they have been associated with worse graft outcome in the recipient. The respiratory system, the issue that we are worried about is the neurogenic pulmonary edema causing a VQ mismatch and hypoxia, which would deleteriously affect the organs as well. Monitoring is as per usual with our goals to maintain tissue oxygenation and protect the lung for transplantation. Avoid APO and aim euvolemia and apply lung protective ventilation with low tidal volume, low FiO2, PEEP of 5 to 10 with a low PEEPlet. When we talk about the endocrine system, a cessation of blood supply to the brain causes a disruption of the hypothalamic pituitary axis, which leads to a low TSH and low ACTH level. Low ADH levels can cause diabetes insipidus, which causes polyuria, leading to hypernatremia, high serum osmolarity, and hypovolemia. In my center, we regularly give hormone replacement therapy for the patient. In patients who have low blood pressure with DI, vasopressin would be the drug of choice to increase the BP. However, if it is hypernatremia without hypertension, then it would be desmopressin. Glucocorticoids have been associated with increased mortality in patients with ICB, so should not be given until the patient has been pronounced and confirmed to be brain dead. But after the patient is diagnosed as being brain dead, it should be given. Usually we give methylpred 1 gram OD, okay, and they can also help with the hemodynamic instability of the patient. Okay, they help in the hemodynamic to keep the patient hemodynamically stable. There was a study which showed that patients who had been given corticosteroid had 20% less need of vasopressor compared to patients who did not receive the corticosteroid. Thyroid hormone, in all literature, they recommend giving in patients who have hemodynamic instability, but then it is very expensive and we do not regularly use it in Wilayah. High blood glucose level is common in patients with brain dead. It could be due to the treatment, the drugs that we are giving, as well as due to dextrose solutions. And hyperglycemia has been associated with very poor transplant organ function. It should be treated aggressively with insulin infusion. And the last part of my slide is anesthesia for organ retrieval. Please bear with me for a little while more. In the first place, we have said that these patients are all dead. Okay, so why are we giving anesthesia for cadavers? Doesn't make sense, right? But it has been said that dramatic perioperative hemodynamic changes occur in these patients. It's because of the persistent higher brain and spinal function. There's a mean increase of BP by 31 millimeter mercury and mean heart rate increase by 23 beats per minute. In this editorial by P.J. Young, he mentioned a very nice quote. The act of organ donation is a final altruistic one, and we should ensure the provision of general anesthesia at least sufficient to prevent the hemodynamic response to surgery. These are the references for this part of the topic. When we talk about time of organ procurement, our aim is, of course, the best possible organ quality during retrieval. But there are many, many other factors that we need to think of. We need to minimize the time between retrieval and transplantation, but we need to minimize the risk of transmitting infection from the donor to the recipient as well. What the family members want, how fast they want the body to be back for them to have the funeral is also important. The needs of the ICU staff and the ICU bed has to be taken into account, and the availability of operating room staff and the retrieval team is important as well. The cold ischemic time is an interval between starting cold perfusion of the organs in the donor body until normal blood perfusion is restored once the organ is in the recipient. The organs are kept cool to reduce metabolic demand. The limits vary for different organs. For the heart, it's only about 4 to 6 hours. For the liver and pancreas, they need to be transplanted within 12 hours, and for the kidney, within 24 hours. So our pre-anesthetic preparation involves cross-match blood, preparing resuscitation and vasoactive drugs, preparing heparin, because heparin is routinely given to all patients. The dose can be discussed with the surgeon. It's usually about 300 international unit per kilo. Any supportive measures, antibiotics, insulin started in the ICU should be continued into the intraoperative period. Monitoring is as per any other major surgery that we would do. You should anticipate large fluid shifts and hemodynamic changes. Cardiac arrhythmias are very frequent, so correct all electrolytes. Some patients may even need cardioversion, so prepare the resus trolley with you. Lung protective ventilation should be applied and the patient should be kept warm. We usually give neuromuscular blocking agents to the patients. Okay, as we have discussed before, spinal reflex is something common in this patient, and you do not want any patient movement while you're transporting the patient to the OT. There was a case, I think a few years back, where a patient was pushed to OT for a procurement surgery and the patient suddenly moved. And of course, no one was comfortable doing the surgery after that. The patient was pushed back to the ICU, and ancillary test was done, which proved that the patient was really, truly brain dead. However, by then the family refused for donation. Okay, so once the patient has been confirmed to be brain dead, you can give neuromuscular blockade before pushing the patient to the OT. It will also help optimize the operating conditions for the surgeon. Volatile anesthetics may contribute to ischemic preconditioning and improve graft function in the recipient. You do not need to aim a MAC of 1 or even 0.8. A very low MAC, 0.4, 0.5 should be more than enough. Opioids are given to attenuate reflex sympathetic response, to attenuate the hypertension as well as the tachycardia. So the procedure starts, the surgeon does midline laparotomy from the xiphoid up to the pubis. Okay, sometimes they open up the chest as well. They do a thorough visual inspection of the organs to look for any undiagnosed disease. All the patients will have a routine ultrasound prior to the surgery, but sometimes there are things that can be missed, things that cannot be seen in an ultrasound. Sometimes a normal liver can be seen in the ultrasound, but then they open up, it's a cirrhotic liver. So you are not going to take this for the patient. So they thoroughly inspect everything, and then they would dissect each organ and prepare for the rapid ligation, dissect each organ and identify all the structures. In case the patient goes into hemodynamic instability, they will rapidly ligate all the blood vessels and take out the organs. Subsequently, the thoracic aorta, abdominal aorta, or both are cannulated. This is the time the surgeons would ask you to give the heparin. So the heparin function is to prevent any thrombosis in the graft organ. Immediately after the heparin is given, the aorta is cross-clamped and the aortic cannula are flushed with cold perfusit. Then the heart stops to beat. The ventilator and monitors can be turned off, and you can leave the operating room if you wish to. The organs are then bathed in an ice slush to cool the organs. And the organs are then removed according to cold ischemia tolerance of each organ. So the heart, the lungs, the liver, and then the kidney. So usually if the heart and lungs are taken, they are then transported to IJN for transplantation there. The liver goes to Selayang, and the kidney, 2 kidneys, one goes to Selayang, one to HKL. So to recap, you should identify a donor when the gift sign is there. A brain death test should be done for this patient, and you should anticipate spinal reflex in this patient. Okay, if the family agrees for organ donation, the patient should be, the organs should be managed adequately in the ICU to ensure that they are in good condition to be transplanted to the recipient. Continue all the ICU supportive management in the operation theatre and make sure and hopefully the surgery goes on well and the donor gets a good quality organ. Thank you very much.